Welcome everyone to this discussion on our upcoming issue on glomerulonephritis for nephSAP. I'm Martina McGrath. I'm a transplant nephrologist at the Brigham and Women's Hospital, and I also work at the VA Boston, and I'm the deputy editor of nephSAP. And I'm joined here today by Dr. Joyita Bharati, who is a nephrology fellow at Boston Medical Center, and Dr. Laurie Beck, who is an associate professor of medicine and the David Salant Professor of Nephrology at Boston Medical Center, and really a world leader in the field of membranous nephropathy with, I think it's fair to say, one of the most significant contributions to our understanding of the disease process so far to date. So I'm delighted to have a few minutes to chat to you both, and thank you very much for joining me.
Thank you. It's nice to be here.
I wanted to open up the discussion a little bit to talk about your editorial that you wrote for our upcoming issue, which I think is incredibly important given some of the advances that we've seen in drug approval for glomerular disease over the last few years. And just to give our audience a little bit of background, can you tell us this discussion around surrogate endpoints in glomerular disease? Where are we at the moment, and where have we progressed to over the last few years?
I guess I can start with that. So I think we're in a field that, is still, in terms of clinical trials, looking at endpoints like proteinuria, progression to some renal endpoint like end-stage kidney disease, or looking at a decline in eGFR. And we haven't yet been able to fully utilize, I think, some of these newer molecular discoveries like antibodies or other plasma or urine markers that might help us as surrogates of molecular mechanisms. And that was one of the thoughts I had coming up with this guest editorial for nephSAP.
And I guess we hear a lot about changes in proteinuria as a surrogate endpoint, particularly in the IgA trials, and that's been used pretty successfully for expedited approval. And can you explain to us a little bit more about why changes in proteinuria would not be a suitable surrogate endpoint in membranous nephropathy?
Mm-hmm. Joyita, do you want to start with this one?
Yeah, sure. So what I'm learning and what I'm understanding is that in terms of membranous nephropathy, proteinuria, remission of proteinuria takes a longer time, maybe because of the pathogenesis, and then the resolution of the whole process takes time, the GBM distortion, and then, the resolution of that again takes time. So as also we see in the clinical trials, like the bigger trials, Mentor, etc., we see that the clinical remission rates, like complete remission, happens only after like about 24 months or so. So it takes a longer time for remission. I think that's number one reason that for clinical trials, feasibility in terms of time endpoints, it's a very lengthy process. So that's number one, what I can think about, which is one of the barriers in getting us more trials in membranous nephropathy as compared to IgA, which kind of happens over faster times. Like with the newer drugs like iptacopan and ravulizumab, we see that even within 6 weeks or 8 weeks, we're seeing a drastic reduction in the proteinuria, which doesn't happen with membranous as of now. That's something which comes to my mind immediately. And I think others, like we do know that the threshold for proteinuria remission in membranous nephropathy is much higher, like a proteinuria of 4 grams or so. Could also become could also end up having a spontaneous remission as compared to IgA, which usually doesn't have spontaneous remissions. Then Dr. Beck, if you want to add.
Yeah, I think, it would be nice if all glomerular diseases behaved like minimal change disease, right? So, you have someone who's fully nephrotic, you give some immunosuppressive therapy, and then within weeks, they may go to a complete remission. Membranous nephropathy is somewhat the opposite of that, I would say. You can give initially the modified Ponticelli regimen with cyclophosphamide and corticosteroids for 6 months, and then you sort of wait it out for really years until you start to see a lot of the remissions. And when you have a trial that's been designed for multiple years and they've gotten the input of multiple thought leaders in the area, and then finally you start the trial and recruit, and you have maybe 24 months before you need to come up with an endpoint that's going to be the decisive, does this drug work or not? it's tough in membranous nephropathy because it just takes longer for these deposits, which have been forming probably for like a year before the patient comes to clinical attention, and then to ask to get rid of the circulating antibodies, and then to ask the deposits to go away and the podocyte to get back to normal takes a long time.
So I guess it sounds to me like those somewhat hemodynamic effects that we see in drugs like ACE inhibitors and SGLT2 inhibitors that can really drop the proteinuria, and something like IgA nephropathy, the magnitude of benefit really is not the same given the underlying pathophysiology and what's going on there with an antibody-mediated process.
Yeah, I guess ACE inhibitors have never been thought to work that well in membranous nephropathy, maybe just because you're starting with such high levels of proteinuria, 10, 15 grams sometimes. I think certainly hemodynamic, reducing glomerular filtration to reduce proteinuria is useful, but it's not going to be the final answer. And the same thing for IgA nephropathy. There are drugs that do seem to work more with glomerular hemodynamics to lower proteinuria, and those get the same endpoint as do the complement inhibitors, which work completely differently to inhibit the complement activation in the mesangial deposits, and then exactly how that leads to decreased proteinuria. I don't think we have a full answer, but those then tend to go from a starting proteinuria that can be nephrotic, but is more often subnephrotic, down to something that's acceptable for approval or accelerated approval these days.
One of the things you've alluded to in your editorial is the KHI initiative between ASN and FDA, and how that has been very successful in the IgA space, and similar attempts to come up with a mechanism for diseases such as membranous nephropathy. Can you expand for us a little bit more about what's been done in trying to think about endpoints that regulators might approve of for membranous?
Right. It's been difficult. And there was a FDA, I'm not exactly sure if it was a KHI sponsored but it was certainly, first author was Eliza Thompson, and there were membranous nephropathy experts that came up with a surrogate of complete remission as probably a good indicator of a drug efficacy in membranous nephropathy. And complete remission meaning less than 0.3 grams per day. Which, as Joyita said, is somewhat difficult to get to in a 24-month trial. But that's really been the only work that's been done to define an endpoint specifically for membranous that might be applicable to trials. And it's only been in the last few years that, and part of this was my naivete. I'd been part of a externally led drug development, FDA drug development workshop in membranous. And I think my talk was on design of clinical trials. And I said, yeah, we should all be following anti-PLA2R in the clinical trials because it's the first thing that happens. And very quickly after that, there were requests that maybe the scientific community should gather to discuss this option, because use of anti-PLA2R in a clinical trial really wasn't feasible at this time. So that led to the January 2023 membranous nephropathy scientific workshop, which was sponsored by NephCure. And we're finally getting that report out. That should be available both in Kidney International and Glomerular Diseases in the next month or two. And that also prompted some of the thoughts that went into this guest editorial for nephSAP. Because there are regulatory issues with the current assay that we're using clinically, but can't officially be used as an endpoint in clinical trials. That's what we're trying to get around.
But could you explain that for us maybe a little bit more? Because I guess on the surface, it certainly makes sense that if we think the antibody is causing the disease, that changes in the antibody might be a reasonable surrogate.
Right. Yeah, and it made sense to me because, we noticed this early on. We sort of published review articles that said this was the case. And then, the Mayo Clinic and Dick Glassick's review on the proposal for serological use of in membranous nephropathy, and then finally KDIGO. And I think many of us are using the commercial assay clinically to follow our patients to see if they're responding to therapy, if they're going into spontaneous remission. But what I didn't understand at the time was that the current assay for antibodies to PLA2R is FDA approved for diagnosis as an aid in diagnosis. Meaning, and that even goes around the more recent non-invasive diagnosis where it is proposed that the anti-PLA2R assay can be used for diagnosis. But what the FDA cleared this for was an aid. So you have the right clinical setting, a nephrotic patient, the edema has developed over months, and probably you're going to get a biopsy. So the serology can suggest membranous nephropathy that then could be confirmed. That's a low risk use of a device, right? Because you're not going to use it, and the patient's going to be at risk for a misdiagnosis or misclassification. What we learned about using it for monitoring, which it's not approved for by the FDA, is that you may, especially in a clinical trial, withhold treatment if you get a false negative, continue treatment, which is toxic in itself, for a false positive. We don't know what thresholds we should use for when a patient gets to a significantly low enough level of anti-PLA2R that has a meaningful clinical response. So there's a lot of further information that needs to be collected and submitted to the FDA before anti-PLA2R can be considered as a reasonably likely surrogate.
I would also like to add, Dr. McGrath, that the level at which we say that the PLA2R is negative is also kind of a variable in different studies. Most people, like most authors, would have used less than 14, which was based on the Euroimmune assay. But then the ideal would be to have it like less than 2 relative unit per mils. That's another thing I wanted to just highlight here.
Right, we don't know. We would assume that if it's undetectable by the ELISA, that's enough, but maybe there are undetectable levels that have some significance. I mean, I don't think we'll ever find those, but we're assuming that undetectable by ELISA is enough. But I guess the proof is in the pudding. Let's see the data and show that if you get a patient to that, maybe at one point, or maybe you have to repeat it, have 2 completely negative assays, that predicts response. I mean, I think it will, but the regulators, haven't been shown that information. So it makes sense that we can't officially use that.
I guess for the practicing clinician, this is probably, potentially confusing, because I think there is some messaging in the nephrology community that if we have a patient that has the typical clinical presentation and is PLA2R positive on serology, that maybe we don't need to biopsy those patients. We can presume that they have membranous nephropathy and begin to treat them. Could you tell me your thoughts on that?
Yeah, that's, I think first of all, using anti-PLA2R monitoring is reasonable. There's a lot of observational evidence. FDA has said we can use our discretion as physicians or providers to use something off-label. So that's what many of us are doing to monitor our patients. The use for diagnosis is a little trickier. There have been 2 papers out of the Mayo Clinic suggesting that if a patient has preserved kidney function, so an eGFR over 60, if they're nephrotic, if they don't have any potential secondary causes like malignancy or certain medication use or infections, and they don't have diabetes, that a positive anti-PLA2R gives you a non-invasive diagnosis, and you don't need to do a biopsy. Now, if you go to the KDIGO guidelines, you don't need to do a biopsy if you're not planning immunosuppression. If you are planning immunosuppression, then I think you should more strongly consider a biopsy, because you're giving these potentially toxic drugs, and you want to make sure what the underlying disease is. There have been published and unpublished false positives with the anti-PLA2R ELISA. Many in diabetes. My interpretation of that is, having done lots of immunoblots using serum from membranous nephropathy patients and diabetes patients, is IgG in diabetic patients seems to be stickier for whatever reason. So, when you put serum from a diabetic patient into an ELISA that doesn't have a control well, so it's just a little well with PLA2R in it, and if human IgG sticks in there, then that's counted as a positive sample, the signal. So I think there are situations where you just have sticky IgG that gives a false positive. But if you take that same serum and repeat the test in the other commercial assay, which is a biochip test that has cells that are transfected, so expressing PLA2R, right next to cells that don't express it, so you do have a control there, generally those false positives go away, and it's clear that that's not a true signal for anti-PLA2R. So I think if you are going to not do a biopsy, it might be worth trying to get both assays, just so you're even more confident of the results, especially low titer assays.
Fantastic. Thank you very much. And so I guess, given where we are with the challenges that you've outlined in doing clinical trials where complete remission or partial remission is the endpoint, and the fact that, based on what you described, from a regulatory point of view, it doesn't seem like PLA2R is ready quite yet to be a surrogate endpoint. Where are we? What do you think are the next steps in this process? Where is this going to move over the next few years?
That's a good question. I'm happy to let Joyita give any, if you want to. I've talked a lot. Joyita, if you want to say anything.
I mean, I guess we wrote it, and what we could understand is that we could take examples from the FSGS project that was recently, the interim analysis was presented in at the ASN this last year, and that the Parasol project had shown that they could collect a huge amount of data relatively over a short period of time, and they could use proteinuria. They could find a threshold of proteinuria, which could be potentially a surrogate endpoint. I think what we need for membranous is also like a collaborative effort to gather more samples, larger numbers, and then have that shown, either it's PLA2R or it's proteinuria. I guess I favor PLA2R here, because it's a shorter time to achieve a reduction of PLA2R as compared to proteinuria. I'm sure Dr. Beck has more to speak.
Yeah, I agree that we need to pull together all the available evidence. A lot of problems have been brought up. There isn't just one assay. Other centers may have their own assay. They may use different assays. They may use different thresholds for negativity. Sharing data is tough, especially with industry. The initial mentor trial used not the assay that we're currently using, but a research assay from Manchester, England, that then in a subsequent paper, they remeasured those samples, so we have some better and comparable levels to what clinicians may use here. But there's no standard that we can base. If we wanted to test 5 different assays, we don't have that. We're just sort of using patient samples or what comes with the kits. So that makes it difficult. So, I think anti-PLA2R is a good biomarker for a majority of membranous nephropathy. And we've had now 15 years of observational data showing that it may be a good biomarker, but if we can't even use this, and the clinical trials that once they get approval for this are still going to be, many years in the future before there are any results. So I think, if we can put together a collaborative, and I have a name for it already, which I've shared with a few people, mnemonic. Mnemonic is membranous nephropathy, evaluating markers of outcome to innovate and improve clinical trials. So we'll see if that name sticks, or if we even put together a collaborative group. But I think that would be, there's a lot of siloed data, and if we can convince people to put it together for the utility of improving clinical trials and expediting clinical trials, that would be very nice. Some people have said, do we even need new therapeutic agents? The Mentor study showed that anti-CD20 agents work well in membranous. There's the Majesty trial is looking at obinutuzumab, which will probably also show that an anti-CD20 agent is effective. So some people I've talked to have said, what else are we going to do? You're already achieving a 70-80% response rate over time. Personally, I think there's a lot of other options. Complement inhibition is something that there was an early trial with eculizumab that never got published, probably due to underdosing. But some people are thinking about complement inhibitors. Would that decrease? Would anti-PLA2R be useful in that? Maybe not. So even there, with these innovative therapeutics, maybe the biomarker that we currently have may not be useful. But I think we need to follow anti-PLA2R in studies and hopefully use it someday as an endpoint.
Well, I think you've got a catchy name for the trial consortium already. That's a good start. So thinking about a comparison between IgA nephropathy and membranous nephropathy, both are immunologically mediated diseases where we know there's an antibody involved and there's complement involved. What are your thoughts, or I guess, how have you conceptualized this idea of different clinical trial designs and drugs that target these agents with shorter term outcomes?
Mm-hmm. Yeah, I think it's great for IgA nephropathy, which is one of the points in the editorial, that we have so many different types of drugs that are now initially getting accelerated approval based on proteinuria reduction at 9 months, and then sort of they get out there, and as long as the clinical trial at 24 months shows a more standard outcome like eGFR decline is also improved, that drug is available and is on the market. And this is for drugs that work in very different manner, right? Sparsentan is a dual endothelin angiotensin receptor antagonist. We have a targeted budesonide. We have a complement inhibitor. We may soon have anti-APRIL therapies to work on class switching and B-cell survival. And yet all have this common mechanism of proteinuria reduction without much regard necessarily to glomerular inflammation per se. I mean, I'm sure proteinuria is a result of glomerular inflammation, but we're not looking at hematuria. We're not looking at red cell casts. We're not looking at, I guess we are looking at changes in eGFR, because we're looking at decline over the clinical trial. Could there be biomarkers like antibodies to the galactose deficient IgA1? Maybe that would be another important biomarker that would probably have to go through the same trials and tribulations as anti-PLA2R. But it would just be nice to because we can't have proteinuria reduction, certainly in 9 months in membranous nephropathy, is there something quicker that might play that same role? And an increase in serum albumin has been shown in a few studies to go up more consistently and earlier than proteinuria reduction. So maybe that's a combined endpoint with proteinuria reduction, with anti-PLA2R if it's accepted as a reasonably likely surrogate someday. So those are my thoughts on the two diseases separately.
These are such complex disease processes, and trying to attack them from so many different angles with all these new agents. I think one of the challenges for the practicing nephrologist is going to be where to fit these agents in an individual patient, and how does one choose, particularly if you're thinking about something like sparsentan versus maybe a complement inhibitor or an anti-APRIL agent, and which patient needs which drug, I think, is what we will probably need to figure out over the next few years.
Yes, and Joyita and I and a few other members of our faculty are trying to come up with our own algorithm of how to use these sometimes difficult to get medications for our patients, and you can't have them all because that would be $500,000 per year or something per patient. So coming up with an algorithm about, does this patient have more inflammation than proteinuria? Is this more of a chronic disease? And I think we're all struggling with that, and the ASNs and other, international guideline groups and meetings are struggling with coming out with a way to use these. So it's nice to have so many drugs, but I think it is also a confusing time for physicians, for patients, knowing how best to use them. And I hope we get to that stage in membranous nephropathy.
Wonderful. Well, thank you both very much for your time and for your efforts. This has been a really interesting conversation, and I hope will be a great complement to the editorial. And I encourage everyone to go ahead and also read it and study it in depth. So Dr. Beck and Dr. Bharati, thank you both very, very much for your time.
Thank you
for having us.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition, or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.